Hello, everybody. We are on standby for 3 more members to come to the committee, so we will have a quorum. So while you're thinking about it, turn your cell phone off. And when we get a quorum, either here or in a combination with online, we'll start the meeting. Okay, Amber just reminded me, we are not going to be voting on 1013. I hate that, on the mental health bill tomorrow. And I will take testimony from people who have not testified before. If you've testified before, the other day when we had the meeting, I'm not taking testimony again from people. If you have sent things into us, there will be a sub tomorrow. We have met, we have gone through, read all of those. There's some that we agreed to, some that we didn't agree to, and some that still have a big question mark on how we're going to figure it out. That's where we stand right at the moment. No bill is perfect, but we have taken a lot of suggestions. I think one of the things that might let you know, let you see, we did take out a major thing. We took out the child registry. Nobody's here to say yay.
Yay.
Is that not something, Stan, that was wanted? I got it right. Okay. Okay. So, of course, it still has to go over to the Senate, remember? So we have to work on that. So we are trying to take a lot of the suggestions, and like I say, it's not over. If you see something that didn't get in, it doesn't, you have to ask us if we changed our mind on, or definitely put it out. But and we'll make 50 or 60 copies if it comes off the press in time for us to get it for our members. And the authors will go over the bill with the changes that are in it tomorrow. And the committee members will be able to ask questions tomorrow about the bill. And then we will take, with what time we have left, we only have the room from 12 to 2. So with whatever time we have left, we'll take comments from anybody that has not spoken before, as long as we have time. Okay, let's see. We have a quorum, and I will call this meeting the House Health and Human Services Committee to order. Maybe got in here. Okay, Representative Hawkins, would you like to go first? It's House Bill 1304. It's the Georgia Caregivers Act. Wherever you're comfortable. And we will be working off LC 540060S. Is that what everybody has in their packets? Okay.
Thank you, Madam Chairman. To the members of the Health and Human Services Committee, I bring you today HB 1304. It's entitled the Georgia Caregivers Act. You're looking at a substitute. Before I begin speaking to the bill, let me just inform you that the substitute came about by an addition of a code section on line 59, that code section 319-2. That's consent for medical and surgical treatment. So you will see different code sections in this bill. These are all 31s, which are in health. Many of them are in different chapters, either definitions of hospital, caregiving facilities, whatever. This bill helps provide clarity for the patient and a smoother transition to either a home or a special care facility. This bill speaks to giving the patient the opportunity to identify a caretaker or caregiver, rather, when they go into the hospital. It does not force the caregiver into any obligations. This is elected for them. It does not delay the discharge of the patient by the hospital. On page 2, you will see definitions, and at the bottom of page 2, the bill actually starts on line 35. This speaks to giving each patient the opportunity to identify one caregiver. That's line 36. On line 40, you see that it does not obligate any individual to perform any aftercare tasks for the patients. And this is in here because often we see patients being discharged sooner than they used to. So more aftercare is going to be required, like wound healing. The patient identifies the caregiver as they go into the hospital. Before discharge, the hospital will contact that caregiver, tell them of the discharge date, and also have them come in with the patient and the caregiver and give instructions after care. At this point, the caretaker may say, I can't do that. It's better to know then than to have them go home, be admitted back to the hospital. And often the hospital is not reimbursed for that admission. So that ups the healthcare cost for everyone. And also it allows that patient then to be moved to a post-treatment type of situation, aftercare, post-care facility. And hopefully that's identified before the patient's discharged. So there's a much smoother move of that patient. On line 43, this does not be construed to require a patient to identify a layperson. In other words, they're not forced to do that. Line 44, 31-36-4, this is the healthcare powers delegation section of code. Number 1 on line 47, notify the caregiver the patient's discharge to the patient's residence, transferred to another hospital or another hospital. And on line 49, it speaks to the lack of the contact to the layperson does not delay the discharge from the hospital. In other words, if they can't find the layperson, they can still be discharged. Then on line 52, it speaks to the hospital shall actively engage with the patient and the caregiver with discharge planning. Then in section 31, 36-5, nothing in this paragraph should be, or this bill should construe interference with the rights of the patient or other person legally authorized to make healthcare decisions. This is chapter 32 of the Advanced Directive Code. Then, which I referred to earlier on that section 31-9-2, that's a consult for medical and surgical treatment. And then on line 61, it speaks to the chapter shall not delay the appropriate discharge or transfer of the patient. On line 62, it speaks to the interference or supersede a healthcare provider instructions regarding Medicare certified home agencies. Line 65, it creates a private right of this bill does not construe a private right of action against a hospital or hospital employee or authorized agent of the hospital. In other words, hospitals should be held harmless, which is very important. Madam Chairman, that's the bill.
Questions from the committee? Representative Mitchell.
Madam Chair, and I know this is a good bill that's brought by my friend, Representative Hawkins. I see here, and I'm most interested in this act in that who assumes the liability? Hospital knows better. Hospital assumes that it would not be in the best interest of the patient to release them to a lay person. But this bill says, regardless to that, the patient can elect to have a lay person. Who assumes the liability in that instance?
Are you talking about the liability of the aftercare?
That is correct.
No one's liable for the aftercare with this bill. You're not going to be accusing the layperson or the hospital. This bill is not construed, nor was it written to provide regress against anyone. This is a positive bill which speaks to aftercare for the patient, which is most important, especially in these days when those patients are being dismissed a little bit earlier time than they had before.
Yeah, well, that's a very interesting concept. So hospital believes that it would be in the best interest not to release them to a lay person.
Oh, no, this bill allows the release to a layperson.
But,
This bill-
but if they believe that it was not in the patient's best interest to be released to a lay person, but they are required to do so if the patient so elects, and then there is some episode that that is the patient is harmed, no one is held liable for that?
It's just like today. The hospital is releasing the patient, and this bill is about notifying a caregiver. Okay. And if that caregiver will make the decision if they will take care of them at home or the traditional route, they'll be released to another facility that's got post-care. And that's it. I mean,
Yeah,
we're
interesting.
not looking for liability in any of this.
Yeah, I do know some professions that would be looking for liability.
It wouldn't be yours, would it be, Representative
I'm
Mitchell?
sorry, you're left out on this bill.
I mean,
don't know.
if the person, Representative Mitchell, if I'm going to be discharged and I choose that Amber is going to be my caretaker when I get home, I'm the person that's responsible if something happens to me.
So the patient is going to assume the liability?
Well, yeah. I mean, if they're, if they're making the decision, I mean, they're not going to let pediatric patients or children that are not of age make that kind of decision, but adults have a right to have some say in their care and to decide who they want to be their caretaker.
Yeah, I could foresee some smart plaintiff's attorney saying the hospital knew or should have known that this was not in the best interest of their care when they released them. I'm just supposing.
They do that every day, whether this bill stands or doesn't stand, that happens every day. This bill just delineates a caregiver and what can happen. It prepares someone to take care of this patient much better than ever before. That's what this bill is.
I mean, I think what it's getting at is, and I can't tell you in my nursing career, which has been a while since I've hospital nursed, that you would have an 88-year-old patient going home with his 86-year-old wife, and both of them really maybe not understanding what the person's going to need to do or
Absolutely.
what it entails. And this would allow them to pick somebody else that, is better suited to give, to help them get better. What I think what's happening, and I'm sure that somebody from the hospital group can tell you that, don't you get dinged if they come back within 30 days that the hospital has to pick up the bill? And so much of this is because they didn't understand, tell me if I'm wrong, Deborah, that when they were being discharged, the patient maybe, because they're in there for something and they're certainly not totally healed, but they didn't understand how they were supposed to take the medicine, that they stayed on their antibiotic and they finished it till the end. And so the infection flares up again. So this allows for them to choose somebody who could help them follow the hospital's directions to better care for themselves, to try to prevent readmissions.
Exactly.
So, but I'm sure you're right. Some trial lawyers can find something to, and it's one of the reasons that, we have fewer doctors in the state of Georgia. I just got through talking to emergency room physicians this morning, residents, and, the professor said, I'm saying to them, oh, you're all going to stay in Georgia when you finish. And what they're saying, the professor says, I don't think they'll all stay. And I said, well, we really need them. And they're going, well, there are other states that the malpractice situation is much better. So it's one of the problems that we have. And while I'm at that, we have a guest a senior in her third year of residency, Jessica Walsh O'Sullivan. Jessica, stand up. Who's coming to sort of be with us for a while. And she's going to stay in Georgia, another year of fellowship in Emory. And then she owns a horse farm out in Conyers. So she's going to be staying with us to practice medicine in Georgia. And even better, she has a corgi. So we'll go back to Representative Lott.
Thank you, Madam Chair. Just for clarification, and I know it kind of got a little bit confusing, but this doesn't change anything in the manner in which a physician is going to determine release, correct?
No, it doesn't.
And so that all remains the same. And then and again, help me understand this. This just appoints someone so that in the example that the chair lady used, if the daughter is the caregiver, but there happens to be an 88-year-old spouse and 86-year-old spouse in the room, that those instructions aren't given under the assumption that those are the caregivers, that now there is somebody just appointed, assigned as the caregiver, and they must then reach out to the person being, in my example, the daughter.
The hospital will notify the caregiver that the patient's going to be discharged. Then the hospital will bring that caregiver in with the patient and give instructions on aftercare. Then the patient's dismissed. Most hospitals are already doing this, so it's not punitive upon them. It just puts in code what is good practices for dismissal of a patient and their aftercare. That's all this does.
And one further question.
Sure.
Have there been any, are there any questions relating to how the hospital is going to, I did read in here where it said that there's nothing punitive if they can't reach the caregiver.
Right.
But of course, we have to have someone sign discharge paperwork.
Right.
So and the hospitals are okay just managing that next step, which is now locating the assigned caregiver.
You will hear the hospital speak in a few minutes.
Okay.
They're going to testify. Yeah.
Thank you.
And 40 other states, you've got a handout, 40 other states have already approved legislation similar to this. Some of our hospitals are already doing this in the state and getting good results as far as less readmissions, but some are not. And so this is just about to, say how important this is and to encourage more people to do it. Representative Shrupper.
Thank you, Madam Chair. Just at the appropriate time, I would like to, say that we pass this bill
Thank
at the
you.
appropriate time.
Okay, at the appropriate time, we'll do it. Okay, any other questions from members of the committee? Okay, we have people that have signed up to speak. Do we have our people that want to speak on this bill? Okay, this is 1304, 1304. Okay, Deborah Stokes, you're first on the list.
Thank you, Madam Chair and members of the committee. My name is Deborah Stokes, and I'm Executive Director of the Georgia Council on Aging. On behalf of the council and the more than 1,200 members of the Coalition of Advocates for Georgia's Elderly, or COAGE, which I'm sure you're all familiar with, we are grateful for the opportunity to present HB 1304. The bill allows a caregiver and patient to be actively engaged in the hospital discharge planning process, tailored to each patient's aftercare needs. As of now, there are 41 other states that have passed similar laws, resulting in notable improvements in the education of caregivers when it comes to the patient at-home care. As you know, each year COAGE engages with its members to determine the most pressing needs facing our aging population in the state. After a rigorous process of review and evaluation, members vote on the top concerns that require further research and work groups to determine which will be presented as our legislative processes, our legislative priorities for the upcoming year. This was one of COAGE's 5 legislative priorities for 2022. In cooperation with our advocacy partners, AARP Georgia and the Georgia chapter of the Alzheimer's Association, COAGE selected the Georgia Caregivers Act. Thank you very much for your time. We have presentations from representatives of AARP and the Alzheimer's Association.
Nancy Petra.
Thank you, Madam Chair and members of the committee. My name is Nancy Petra, and I'm the Director of Advocacy for AARP Georgia. AARP Georgia has been working on this legislation, and we're so thrilled to be here to present it to you today in coordination with our community partners. But we also worked for many months hand in hand with the Georgia Hospital Association on language so that this could be a good compromise and we could bring a bill today that would be a win for caregivers, but also to lower those hospital readmission rates that we've been talking about. So on behalf of the more than 1 million AARP Georgia members, we're grateful for the opportunity to work with the Georgia Hospital Association and our advocacy partners on this legislation. Across our state, caregivers help their older parents, spouses, adults, and children with disabilities and other loved ones so they can live independently in their homes and communities. They assist with meal preparation, managing finances, transportation, and much more. And more, these caregivers are performing medical and nursing tasks for their loved ones, like complex medical management, wound care, and injections. We believe that House Bill 1304 is a no-cost, common sense solution to provide the instruction and training that caregivers need to perform these medical tasks at home. So the act really requires 3 elements. It's the identification of a caregiver by the patient when they're admitted to the hospital. And so as Representative Hawkins explained, if the patient doesn't have a caregiver or doesn't want to identify anybody, the obligation is done at that point. But then if the patient says, yes, Nancy Petra, my neighbor, is going to come over and perform, take care of all of my medications for me when I get home, then he says, yes, Nancy Petra, and the hospital is going to contact me to say, you've been identified as a caregiver for your neighbor. And if I don't respond in some way, or I do not, decide that I'm not going to do it, or if I don't contact the hospital, this does not slow down the hospital being able to go ahead and discharge that patient and do what they need to do to get that patient home, or if the patient does need to go to some sort of aftercare facility. But it allows me the opportunity as the caregiver to work hand in hand in the discharge process to be able to do the care that I need to do at home. And so that can be complex medication management. It can be wound care. I can tell you recently over the summer, I had to do this where I had to use a durable medical equipment at home to flush out someone's mouth after surgery because they had had that blood pooling in there for weeks and weeks. And so that can be complicated, and that can be something that can be overwhelming to a layperson, but people are doing this more and more to keep people at home. And so we want to be able to ensure that they can continue that. And we want to be sure that they get the instruction that they need. And there are videos out there. The Home Alone Alliance has created how-to videos on wound care, specialized medical equipment, transitions, and things of that nature that can help these caregivers and can be utilized by the hospital and the caregivers for this type of education and training to make it simplified process. And then the last thing I just want to add that we have heard stories from caregivers at AARP Georgia who have been fortunate enough to be shown a Zoom video. So one example was there was a video of what she was going to need to do to bring her mom home. And the nurse had the Zoom on and was showing her, here are all the things that your mom is going to need when you bring her home. And she said, I cannot do this. And so she made the decision that even though she had been her mom's caregiver for many years already, that she needed to go ahead and get her into a rehab facility. And that keeps that person from being dropped back off on the hospital door after they come home and they then learn that they can't do these. And so in the 41 states that have implemented this type of legislation, is shown that hospital readmission rates have gone down by 25% within the first 90 days and another 25% within the first 180 days. And this past year, I believe there were 81 hospitals in Georgia that got hit with fines from Medicare for their high readmission rates in Georgia. So we think this is a great time to bring this legislation for a win for caregivers and a win for hospitals. If I can answer any questions, I'd be glad to.
Do you have a question? Representative Mitchell.
A very quick one. what if the designated layperson caregiver is obviously not qualified, but is desired by the patient? Is there no interaction? There is.
So are you asking it? I mean, like so it's really like the patient has the right to decide who they want to care for them at home. They have that right now. We're not changing that. We're just saying that if the patient does say that, Nancy Petra is next door and she's going to come over, that the hospital include me in the discharge planning process so that I can have as much information available to me as possible to do it well. But we're not telling the patient who they can have, and we're not obligating them to do it either under this legislation.
Thank you, Madam Chair.
Representative Mitchell, I will tell you as a registered nurse that if I was in on a discussion, and I can't speak for every nurse, but I think for about 99% of them, 99.9, if they found somebody that was in this situation, if the person that was incapable, say the person they wanted to take care of them was incapable of helping them get up out of bed and move around, and that's what the person needed to do, and maybe the person was small, older, couldn't do it, I can tell you that the person teaching it 99.9% of the time would say something about it to the patient and suggest that this might not be a good idea. I mean, in that conversation, when they are talking about what is expected of the caretaker, it's not like the nurse has to sit there and not give comment. Am I right, Deborah? Okay, Deborah's our, what do they call you now, Deborah? Vice President for, you're what? No, the wrong Deborah. What is it? Government Affairs, but a registered nurse and one of the smartest students I ever had, and did a lot of hospital working before she became, she had this job. So, okay, I'm glad to know I'm still right, know what's going on in hospitals. Okay, Mary Lee? Yep, Boatwright Quinn. Oh, you just hopped up on your own.
I know you like to keep your committee meetings moving fast. So.
Right.
Good afternoon, Chair Cooper and members of the committee. I'm Mary Lee Boatwright Quinn from the Alzheimer's Association Georgia chapter. I'm here to speak to you on behalf of the over 150,000 Georgians who are living with Alzheimer's disease. That does not include any of the other dementias, nor does it include people under 65. That's just the 65 and over number. And we are very much in support of this bill. You may be aware by a personal experience or in just hearing about this, but acute care settings are extremely difficult for people with dementia. They're loud, they're confusing, they're overwhelming. And so when you are providing discharge planning to the patient, they may be in early to mid stage, and they may appear to you like they're gathering all of that discharge planning information, but their short-term memory is depleted, and therefore they're not going to remember any of that. So it's really important that we identify the caregiver and we provide them with the discharge planning information. Also of note is that the readmission rate for people with dementia is actually over 22%. So if we're going to be able to reduce readmission rates, it's going to have an impact on the state's Medicaid budget as well. So we are fully in support of this bill, and I'm happy to answer any questions that you may have.
All right, thank you. No questions. Tim Kibler?
Thank you, Madam Chair. I am Tim Kibler with the Georgia Alliance Community Hospitals. We are a 92 hospital organization made up predominantly of your county hospitals and church hospitals throughout Georgia. Georgia's not-for-profit hospitals. I want to thank Representative Hawkins for the work he's done on this issue. I appreciate the questions you're asking, Representative Mitchell. I think the hope that both AARP and the hospital community have is that as folks leave the hospital, they will be more sure of what the caregiver that they have selected can provide, and the decisions that will be made prior to leaving the hospital will be more fully informed, so that we'll have less likely to have a situation where a caregiver does get in over their heads as they try to help someone who is facing a lot of physical and or medical challenges. But certainly nobody will be leaving before the physician determines that it's appropriate for them to be discharged. So this measure simply seeks to make sure that the people who have said that they will help the patient as they go home are very well informed about what it is they will need to do once they get there, and hopefully make the best decisions possible. As Ms. Peter, I think, said, and I think the chair said there, it's very easy for someone to think that they're going to be able to care for their loved one when they get home and then realize, oh no, I'm in over my head. The goal here is to make sure that they are making, their eyes are open so that the patient can come to the right facility and get the right amount of care after they've left the hospital. I appreciate that AARP has been good to work with on this issue, and I'll be glad to try to answer any questions that any committee member may have.
Never see any. Thank you.
Thank you, Madam Chair.
And last but not least, Anna Adams.
Thank you, Madam Chair, members of the committee. I'm Anna Adams with the Georgia Hospital Association. We represent more than 160 hospitals across the state of Georgia, ranging from large urban to small rural. We'd first like to thank Chairman Hawkins for this bill and for his tireless work in making sure that Georgia's patients do have access to a caregiver that is educated. Also, we would like to thank the AARP for their work over the off season. They've been incredible to work with and have helped us address some of the 2019 Centers for Medicare and Medicaid Services conditions of participation that were instituted to help hospitals educate those caregivers as patients are being discharged. So this very much complements what we're doing in that space. And I am happy to answer any questions if anyone has any.
Seeing none, thank you very much.
Thank you.
And I have a question to anybody, or not really a question, but in response to Representative Mitchell's questions, I think where the lawyer might come in, Representative Mitchell, is that if you have hired somebody from an agency, and the agencies that do home health care do background checks and do expect them to be trained in if they're a nurse's aide or an LPN or an RN, if they did something that injured the patient, then I think there would be a question of responsibility. Am I correct, for the people that work in this area? If the patient wants to sue, that would be the situation. Or if they they paid a nursing assistant. When somebody is working in that response and under a license, there certainly is legal recourse against that person. So, okay, so Representative Sharper, you wanted to make a motion?
Yeah, a motion that we do pass a substitute to HB 1304 LC 540060S.
Okay, do I have a second? Oh, we have lots of seconds. Is there any further discussion on the bill from the committee members? No further discussion? Then everyone in favor say aye.
Aye.
Anyone?
Aye.
Who was that? Hutchinson, we heard you loud and clear. She's on with us by Zoom. Anyone opposed? No? Okay, the ayes have it. Thank you. Thank you. Okay. Representative Rich, I think you have one that should move relatively fast, that personally I think is a great bill. Okay, so this is House Bill 1348. Anything we can do to keep people from smoking in any kind of form is a good bill to me. Okay, so 13. Do I have a copy of this? Do I have a copy of the? Will you tell us the? It's a mine. It's stuck on the bottom of the. Okay, no. Okay, 1348. Okay, here it is. It's LC 540055. Is that what we're working on? Okay, you've got the floor. Sorry.
Okay. All right. Thank you. Thank you, Madam Chair. This is a bill that was requested by the Georgia Department of Public Health. It will update the Smoke-Free Air Act to bring parity to the law to treat vaping and traditional tobacco smoking the same. This issue was brought to my attention by our local health department after an issue arose during a restaurant inspection. I have Dr. Audrey Arona, who is the director of the Gwinnett Newton Rockdale Health Department here, as well as representatives from the Department of Health, who can share more information about what actually gave rise to the development of this legislation. The current Smoke-Free Act was adopted in 2005. This is before vaping became widely popular. We have heard in previous committee meetings about the tremendous uptick in vaping, especially among our youth. It's some statistics from the Department of Public Health are startling. We have only 16.3% of Georgians who smoke. Yet we have more than 21% of high school students who either smoke or vape. So clearly the previously unregulated vaping and electronic cigarette industry has surpassed smoking as a more prevalent threat to our public health. Currently, the provisions of law that prohibit smoking in enclosed places like restaurants, schools, daycare centers, they do not apply to vaping or any other e-cigarette use. Electronic smoking devices, that's a global term that includes a lot of devices that you'll hear about, like vapes, Juuls, e-cigarettes. So I'll refer to them as ESDs to make it go a little faster. These are commonly known as vapor products, but they do not emit harmless water vapor. Their industry has incorrectly used the term vapor here, which has led to the dissemination of some dangerous fallacies about the dangers of what is emitted. These ESDs, in fact, emit aerosol, not just vapor. We have small particles, nanoparticles in this ESD aerosol that contain nicotine and other toxins like formaldehyde, lead, and toluene. Somebody may know how to pronounce that. That's basically a chemical in paint thinner. These nanoparticles are much smaller than the particles in tobacco smoke, and they're present in much higher concentrations. Making it even more dangerous, these nanoparticles are more easily and deeply breathed into the lungs of the user and the bystander. Toxic chemicals attached to these nanoparticles can therefore have an even greater adverse health effect than when these toxins are attached to tobacco smoke. ESD particles can exacerbate respiratory conditions like asthma, and they can constrict arteries. The aerosol can increase the risk of cardiovascular disease and contains cancer-causing chemicals. That is why the Georgia Center for Oncology Research and Education has written in support of this bill. And if you don't already have a copy, I can distribute a copy of the letter from that organization. Studies have found that people exposed to aerosols from these devices absorbed similar levels of nicotine as they did from cigarette smoke. So we have the same effect on bystanders that we did from tobacco smoke. This measure will bring Georgia in line with 21 other states, including our neighbors, Florida and Alabama, that prohibit e-cigarettes in locations where traditional smoking is also prohibited. And this will be a great measure to help protect the health of Georgians going forward. At this time, I can yield for questions, or we can bring up some of our other witnesses to testify.
Two ladies that are with you, do they want to just have them
I
come up
believe.
and identify themselves? And
Okay.
one
Does
at a
anybody
time?
want to speak?
Madam Chair, committee members, hi. I am Audrey Arona. I'm the District Health Director for Gwinnett, Newton, and Rockdale County Health Departments. And the way this came about, we have environmental health specialists who routinely perform restaurant inspections. And during one of those restaurant inspections, a consumer complaint arose from that due to a patron who was vaping. And so my chief operations officer went back and looked at the law, found the loophole, and then we just simply notified the state. That's how this came about. Thank you.
Thank you. Okay, Megan?
Hey, everyone. Megan Andrews. I'm the Assistant Commissioner for Policy at DPH. Dr. Arona brought this issue to our attention, and so we are pursuing it as an agency bill this year and would appreciate your consideration of this important measure. And we're here to answer any questions you may have, but I think there's other people signed up.
Are there questions for Megan or the doctor? Don't see any. Okay, we'll start down the list. Polly McKinney.
Hi, everybody. I'm Polly McKinney, Advocacy Director at Voices for Georgia's Children, and we are in full support of this legislation. Just to highlight a couple of quick things about how important this is for kids. As Representative Rich mentioned, a lot of folks who start vaping end up smoking as well. And 10% of high school students say they have smoked e-cigarettes within the last 30 days. In a school survey of 2020, 13% of high schoolers have reported using e-cigs or vapes at least once. 1 in 4 high schoolers believed e-cigarettes were more acceptable in society than cigarettes, and nearly 1 in 3 reported they believed they were less harmful than cigarettes, just to give you an idea of the scale of the problem. So we urge your support of the bill. Thank you. Happy to take questions.
Okay, Richard Ward.
Thank you, Madam Chair, members of the committee. I'm Rick Ward with the Georgia chapter of the American Academy of Pediatrics, representing the state's pediatricians. We're 200% behind this bill for all the obvious reasons. Thank you.
Bella Pope.
Madam Chair, members of the committee, my name is Jamila Pope. I'm the Government Affairs Director at Children's Healthcare of Atlanta. We are also in full support of this bill. You've heard some wonderful statistics about why this is so important. I won't belabor the point. We are in support and would ask for your favorable consideration. Thank you.
Okay, Lynn Perham.
Thank you, Madam Chair. I'm Lynn Durham. I'm the president of Georgia CORE, the Georgia Center for Oncology Research and Education. I spoke to you a few weeks ago, which I appreciate very much. I just wanted to come up and say we absolutely support this legislation. We're very concerned with the data that's coming out that more and more young people are smoking. Are having vaping and e-cigarettes. We don't know the full long-term effects of that, but we are in the world of cancer, and we want to make sure that we are stopping as many people as possible from getting cancer. So thank you. We're very much in support.
Apologize about your name. That D looked like a P.
I will have to get on George Ray about that. He wrote my name wrong.
Oh, okay. Going. Andy Lord.
Good afternoon, Madam Chair, members of the committee. I'm Andy Lord. I'm here on behalf of 4 organizations, all supportive of this legislation. The first is Healthy Mothers, Healthy Babies of Georgia, where I enjoyed working with your now colleague, Amber Mack. The Georgia Society of Clinical Oncology, the American College of Physicians Georgia chapter, and also Georgians for a Healthy Future. All 4 of these organizations stand in support of this bill and urge the committee to pass.
I take a minute just to give you a little history lesson. In 2005, when the first bill passed that Representative Rich mentioned, I was sitting at my desk, and all of a sudden I had about 5 senators surrounding my desk. And I'm going, what's going on? I'm sitting there. You've got to kill this bill. You've got to kill this bill. I said, what bill are you talking about? We just passed a total smoking ban. And I said, well, I'm all for that. Why would I want to kill that bill? I said, did it pass by just 1 vote or something? Oh, no, it passed almost unanimously. And I went, whose bill was it? And they said, oh, it was Dr. Thomas's. Well, Dr. Thomas was a little dried up family practice doctor of about 75 years of age. He's still alive. And he was my counterpart in the Senate. And everybody loved Dr. Thomas So they passed the bill out almost unanimously and sent it over to me to kill. And unfortunately, I love Dr. Thomas too. But there were people above me also that had different ideas about a total ban. And we got the best we could. So I'm Representative Rich for bringing this, anything we can do. Like I say, I would vote for a total ban at any time. I would vote to raise the tobacco tax. If you have ever seen anybody gasping for breath when they have cancer of the lungs or COPD and the other things that go in great part from smoking, you would understand why I'm so passionate about people not smoking. Thank you.
And to that point, Madam Chair, I can't let it go unsaid after your commentary that we do have the 48th lowest tobacco tax in the country. And I hope to have an opportunity to revisit that in the future in this committee as
Maybe
well.
one of the reasons they don't let the two of us run the zoo. So anyway, I would just give all the money to healthcare. So that's why I'm not on appropriations. So and I want, okay, what is the will of the committee? We have got a thing to do pass, seconds. Everybody going to second? All right. Any other discussion? All right. I don't see anybody that wants to say anything else. So everybody in favor, say aye. Anyone opposed? Just try it. No, I'm teasing. I'm teasing. Anyone opposed? Okay, the ayes have it. Thank you very much to the committee.
Thank you.
You're welcome. Okay, let's see. All right. So we are going on to Miss Dempsey. And you are bringing for us House Bill 1355. I ended up with so many pieces of paper. 338986. You've got.
Thank you, Madam Chairman. I appreciate it. This bill comes to us developed from the findings of the House Study Committee on Childhood Lead Exposure that convened this past summer and fall. The members of that committee, I chaired it, and then also Carla Drenner, Matthew Gamble, Misha Maynor, Mark Newton, Dr. Chris Rustin with DPH, Tara Buchholz, who may still be here, House Budget and Research Office policy analyst, helped guide us through this process. It was very informative. Of course, we were also doing this on the behalf of the Department of Public Health. Commissioner Toomey, Megan Andrews, and Katie Smith have all worked very hard on this too. So protecting children from exposure to lead is important to their healthy development. According to the CDC, there's actually no safe blood level in children, and even small amounts have been shown to affect IQ, attention span, and academic achievement. The most vulnerable are children under 6 years of age, children living at or below the poverty level, and those who live in older housing. Despite an increase in policies to prevent exposure to lead, the CDC still recommends that states implement robust lead detection programs, as the consequences of early exposure to lead are so severe and often irreversible. Although the goal is to prevent any exposure before it occurs, lead still persists in so many places. I just noticed as we were talking about vaping that is some of the byproducts in vaping as well. It's mentioned in that information. So you see it in older buildings, housing units. Children can also be exposed to lead in the soil, drinking water, and even in the air. Very near to where we are today, over close to the Mercedes-Benz Stadium, it has been designated a super site by the federal government for lead that is within the soil there. So pervasive problems exist. The Department of Public Health conducts lead prevention activities, including case identification, identification of exposure sources, environmental management, and lead hazard reduction. Just recently, while we were meeting, the CDC updated its recommendations on children's blood lead levels and recommended that interventions occur when blood levels reach 3.5 micrograms of lead per deciliter of blood. Under current law, the Department of Public Health intervenes when blood levels are at 15 micrograms. So missing a population of children that have been exposed is our challenge right now. This also prevents the state from pursuing enforcement against landlords until the blood level reaches this level. Under proposed language in this bill, the law would be updated to comport with the current CDC and EPA guidelines for blood lead levels. This would lead to more robust program for identifying and preventing cases of lead poisoning in Georgia, thus protecting Georgia's children. There's an anticipated budget impact of a little under 1.8 million to DPH to fund additional lead inspectors and supplies throughout the state to handle the anticipated increased caseload, which is why this legislation is contingent and important today as we begin to wrap up our House budget going into the current hearings on that. It is a part of the conversation. That funding is a part of the conversation. So that is alive. That should not be an impediment to it. I would direct you to some of the information I think that are in each of your folders too. There is some information for how health departments will implement this, and also a map which shows some pretty vibrant hotspots in Georgia that have too many children. This is from 2019, but too many children that actually do have exposure to lead right now. That is the presentation. We may have Dr. Rustin here, who was a part of the study committee. If there are any technical questions, if he could come sit with me, and if there are any questions from the committee, that would be great.
So we are certainly in support of this bill, obviously. I want to thank Chairman Dempsey for allowing us to be part of the House Study Committee. This is something that personally I've been working behind the scenes on for over a decade, behind the scenes, because CDC lowered blood lead levels in 2012 to 5 micrograms per deciliter. And at that time we were behind, and now it's been lowered to 3.5 micrograms per deciliter as when public health actions should be taken. And so I'm happy to answer any technical questions if the committee has any.
I think one of the key things to me was, if I understood right, and if I do it from the first time we went through this, to, get out some of the lead paint in buildings, that the lead, if it causes brain damage, that's not reversible.
And that
It's
is correct
permanent.
in most cases. Yes, you're absolutely
Which
right.
is one of the biggest, most devastating things about this is the brain damage that occurs, which then interferes with their learning and lifelong ability to take care of themselves. Okay, Representative Sharper.
We really, really need to do what we can to pass this bill 1,000%. For one, because of the health with the kids and children, but also at the bottom of this map, that red dot is the county that I live in. So we need to make sure this is done, y'all. All right, do it for me. Do it for me, the red. No, but thank you for this, and it's really important. Thank you.
I don't know that we love you as much as we love Dr. Thomas.
Oh, really?
No.
Oh, all right.
I have to say, Dr. Thomas was quite a thing. He used to drive barefooted here, and one morning he arrived without any shoes to wear. He forgot to put them on and put them in the car.
Oh, my goodness.
So it was a little bit of a problem with what he walked around with borrowed shoes. And the state patrol knew him because he drove home to Dalton many, many days after a couple of glasses of wine going 90 miles an hour. So they sort of looked out for Dr. Thomas. He was quite a character. We do. I'm teasing you, Representative Sharper. So do it for Representative Sharper. Okay. Other members, Tankersley.
I just I too am in the red, so vote for this bill for me as well. I was not aware, I've heard all my life of lead-based paint being the cause. And when you say drinking water, does that imply like a cause such as lead pipes? Or-
Yes, it can. The majority of children in Georgia are exposed through lead paint. However, you can be exposed through leaded pipes. If the water's corrosive, it can leach the lead out. A lot of the old service lines that were installed in the 50s were leaded. Some of the solder that was used to join the pipes had lead in it prior to the mid 80s when it was banned. And so there is some risk from water. However, most public waters, well, all public water systems are regulated for lead. And so if the water system, whether it be Statesboro or whoever manages that water system, they are looking for that. And if lead is detected, there's things that they can do to reduce that lead from leaching out of pipes. And so there has been obviously major issues with lead in water throughout this country, but we do have strong federal and state regulations to prevent that. About 80% of children exposed in Georgia are exposed from lead paint, which is obviously the leaded paint in the home. It forms lead dust, which the children get on their fingers. It gets in the soil outside in play areas, and that's where the majority. The thing about lead is it made paint very durable, which is why it's still here. It's very durable, and it lasts essentially forever unless it's removed.
But particular attention is paid to lead pipes, say in cities and little towns that still need to upgrade their water systems. And so some folks that monitor water are private, that they're monitoring private water systems, and then others. So who gets all those reports, and how are they given back to the community?
Sure. So Georgia Environmental Protection Division regulates this particular regulation in water. When a city or a water system exceeds a certain threshold, they're required to notify the public. If they don't, Georgia Environmental Protection Division can get involved through their regulatory actions. And they also assist the cities and counties and the small systems with improving their water quality, as well as the Georgia Rural Water Association typically will assist the smaller systems throughout the state.
Thank you. Thank you, Chair.
Question from a former commissioner for her area who loves her area and was very concerned about it, and a great commissioner. So Representative Mitchell.
To my friend, Chair Dempsey, I think this is an extraordinary bill. I really do. I had a proposal a few years back that would have been a little bit more progressive for Georgia in that I wanted to test every child drinking water and their status as it comes to lead, because in most bills that I see are reactive. We don't do anything until after they have contracted it. And I felt that we ought to be more progressive in that let's test before we have these maladies, and why we have so many folk that don't do as well as they could do in school and the like. But I applaud you for your efforts, and certainly, my friend, I'd love to support this and see it to its end.
Thank you, Representative Mitchell. I will tell you, one of, I think, our hardest hearings, as I think back on, and I know we've been joined by Dr. Newton, was some of the information that came out about where lead exists in our own homes and items that are in our homes that we're not even aware of. Older mini blinds, lead, a lot of Christmas trees, they have a tag on them, beware of lead hazard. If you start looking at things around you, some cooking utensils that might be used all the time, pottery, lots of pottery, glass. You remember, I know when I was a bride, getting lead glass was an important thing. Well, I put it away because, that makes a difference. It's pretty interesting how much has been incorporated into our life that we were not even aware of. But today, realizing that is a good time to start reading labels.
Chair Dempsey makes such a great point that I'm compelled to offer amendment that we test every school and public facility in this state. We go down to line maybe 20 something, and where we test every public facility for lead, so as to not have to deal with these maladies after the fact. I'm sure I can get a second and a third. And
Representative Mitchell, even though that is a real good, thing to do maybe for the future, and as much as I would like to see every facility, every school all tested, I think it's beyond the expanse of this one and possibly getting it passed. I remember the first one I did, and I thought the realtors were going to hang me out on rental property and, hang me. out to dry for it. And after some very heated discussions and things, we managed to get. So let's get this one through and then come back with full force and work on expanding it. So I'm not going to recognize you for that amendment. What is the, okay, let's go ahead. I've got a list of people. Polly McKinney.
Hi, it's me again. I just want to say we're fully supportive. Thank you all. Sounds like you're already on the right boat. So
Callan Wells.
Good afternoon, Madam Chair and members of the committee. Thank you for taking the time to hear this bill today and allowing me time to speak. My name is Callan Wells. I'm the Senior Health Policy Manager at GEARS, the Georgia Early Education Alliance for Ready Students. We are an organization that advocates on behalf of children under 5 and their families across the state of Georgia. Last September, it was my honor to present to a committee of your peers led by Chairwoman Katie Dempsey about the effects of lead poisoning on the brains of young children. During the first 5 years of children's lives, their brains are developing most rapidly, forming more than 1 million new neural connections each second. Exposure to a harmful toxin like lead during these early years can have lifelong consequences that you already mentioned, including speech, language, and behavioral challenges, difficulty in school, and learning disabilities. Testing for lead in early childhood is crucial to early identification and remediation. It is our duty as grown-ups to ensure that no child suffers needlessly from the effects of lead poisoning. We urge you to vote yes on HB 1355, and when the time comes, consider the roughly 1.8 million needed to fund the Department of Public Health's lead testing program. Thank you as always for your thoughtful consideration of the health needs of young children.
Thank you, Callan. Will you wait till after the meeting? I have a question to ask you about the mental health bill. Oh, Bennett, Representative Bennett has a question.
Not fair, Madam Chair. I have a question of the authors of the bill, and I do apologize for coming in late. Sometimes we just can't keep our arm in this meeting and our leg in the other. Just a quick question, and you may have already mentioned it, Madam Chairwoman. The difference between the red, I'm looking at the map. Has it been determined why there's such a wide difference in the yellow geographical areas and the incidence of high blood levels in the reddest of the areas? If you've already answered that, I apologize for asking.
Actually, it's a good question. We haven't answered that. What this map shows is the number of children that have been tested to show a blood lead level of 3.5 or greater. And so generally, you will see higher levels in counties with higher populations of children, like Chatham County, the Metro Atlanta region, Lowndes County. So that what this is showing is the red means that's more children that has been tested and shown they have a blood lead of 3.5 or greater. The yellow is the counties that have the least number of children, but I do want to point out that 100% of children aren't tested for lead. And so this is only based off the number of children that have been tested and the data reported to the Department of Public Health.
The follow-up question, I do apologize. So, and you may have answered this as well, what determines what population of children are tested and why is there such a wide, I understand urban versus rural, I understand the numbers, but when you look at the specific groups that are being tested, what determines that, the differences?
So we currently, our recommendations for children, and this is based off CDC recommendations, is that we prioritize testing children between the ages of 1 and 5. The majority of children are tested within that range because, as our previous presenter mentioned, that's children are developing very rapidly, their brains developing very rapidly, and so the effects of lead have a much higher a potential issue on that child. Current federal regulations require that any child that is on Medicaid be tested at age 12 months and age 24 months. And if that child doesn't have a blood lead record, when they show up at a physician's office, it's recommended that they have at least one test between 36 and 72 months. And so we receive a lot of the majority of our data is from children who are on Medicaid. Generally, that can be, as you know, viewed as a proxy for low income, which is also a proxy for living in older homes that are typically may have lead hazards in them. And so that's a very high risk population that is tested. We also have a screening tool that we recommend all clinicians use, regardless of insurance status, regardless of whatever payer source that they are. That screening tool is just a few simple questions that the clinician can ask the parent or caregiver to prompt them to make a decision if that child needs to be tested. So for example, one of the questions that they may ask or that they should ask is, do you live in a home built before 1978? Lead paint was banned in 1978. And so if they live in a home built before that or an older home, that could trigger a clinician to decide to test that child. Another question may be, do you have hobbies such as making pottery or believe it or not, making fish sinkers? A lot of people make their own sinkers for fishing where they use lead weights off of tires to make those sinkers. So these 4 or 5 questions are designed regardless of insurance status for that clinician to ask, and then it can prompt that child to be tested. Generally, the yellow areas, as I stated earlier, have a smaller number of children, but that doesn't necessarily mean all children are being tested in those areas. We have lead problems in rural Georgia, just like we do urban Georgia. What this particular bill will do is it lowers the standard or lowers the blood lead value that prompts public health action. And you will see many more children receiving some level of public health services if this bill is passed.
Okay. Thank you. Okay, Rick Ward. Delete. Oh.
Hey, everyone. Sorry, I'm not Rick Ward, but he wanted me to let you all know he's supportive American Academy of Pediatrics.
Okay. Jamila Pope.
Jamila Pope, Government Affairs.
Sorry.
It's okay. Government Affairs Director at Children's Healthcare of Atlanta. We are in support of HB 1355. We've already heard that young children are of particular risk. And the one thing I would add for your awareness is that Children's Healthcare of Atlanta, our Hughes Spalding Hospital, does regularly stock the drug Sucamir that is used to, I hope I pronounced that correctly, that is used to treat children that have had significant lead poisoning. And I believe that we are the only facility in the state that regularly stocks that. So we urge your favorable consideration. Thank you.
Thank you. And Elizabeth Apley.
Madam Chair, members of the committee, thank you so much for hearing this bill. Chairman Dempsey, Dr. Rustin, Tara Buchholz did an unbelievable job with that study committee. Those resources are incredible. I'm here on behalf of Enterprise Community Partners, Presbyterians for Better Georgia, Georgia Advancing Communities Together, and 9 to 5 Georgia, all of whom are concerned with healthy housing and making sure that children are protected. This bill will do that. We thank you for your deliberations and urge you to support this bill.
Representative Sharper.
You ready for a motion?
Yes, I am.
A motion that we do pass,
Bless you.
House Bill 1355.
Okay, we have a
Second.
I do pass in a second. Is there any further?
Second, Schofield.
Pardon?
Schofield,
You're-
second.
No, it's Schofield. You're getting ahead of yourself. Let me get the words out. So, okay, do we have any more discussion on this bill from members of the committee? No. Okay, we're ready to go. Everybody in favor say yes.
Yes.
Everybody
Yes.
opposed, no.
No.
The yeses have it.
I mean-
Okay, thank you
We
very much
good?
to all the members of the
No.
committee. So, and thank you to everybody that's attended. Remember, we do have the meeting tomorrow. It's very important. We're going to have a new sub on the mental health bill, and we will be taking comments from people who have not commented on before. And if you want to be succinct and you have your comments in writing, you could also give them to me that way. And we'll see how far we get, how many people want to speak tomorrow. Thank you. We are adjourned.
Madam Chair.